Okay, perfect. Okay. Yep. So let me share my screen. So thank you very much for the invitation to be here. Dr. Fada, Dr. Dimitra, and Dr. Feldman, and really enjoyed talking to the residents yesterday and interacting. This is what we've missed in the last 2-3 years, and I'm glad it's back. And I'm hoping that in the future we will interact in many more different forums. What I'm going to talk about today is yesterday I talked a lot about research. Today, I'm going to talk about surgery. And that's because, again, these are very important and interesting times for surgery. And to see the level of bright young people at McGill going into surgery, it makes me very happy because this is such a great field. And I just want to make sure that all the residents and fellows here know you're about to enter into a career that allows you to really help people in the greatest of ways, okay? These are my disclosures. I went through them yesterday. And so let me just go through some of the challenges, okay? And that's because every challenge is an opportunity, okay? And so I go to a lot of molecular biology and cancer biology meetings where they go with all these new effective systemic therapies. Are we going to even need you guys? Are we even going to need surgeons? And I've been hearing that for, half a century. Surgical technology has become really complex. So how do you even keep up? Okay. And so it's become really much harder to stay abreast of all the new things. Advances in biology and medicine are moving at such a fast pace. How do you know what's important in the gene profile and the epigenetics and help our patients using all of the information? And then there's such a tremendous scrutiny of our professional practices and performances now. Making big steps forward is harder than it was 30 years ago. And electronic communications allows an endless workday. When we finish in the OR and we finish rounding on patients, we still have 200 to 400 emails to go through. So how do we go keep up? And then the millennial family is a very busy and fragile social unit. When I was in junior high school, my parents would drop me off first day of school and pick me up the last day of school, and that's it. Now we're expected to be at school. We're expected to participate in all facets of our children's education. And how do we go put that all together? Okay, so I hope that this talk, which will be more philosophic than anything, will help in some way. So I'm going to use the example of metastatic colon cancer to talk about evolution of surgery and how surgeons now fit and always have fit into the paradigm of care of the cancer patient. And this is the most common disease we treat in North America as liver surgeons. And that's because half of the people with colon cancer will eventually develop liver metastases. And that's because of the portal drainage of the colon and the rectum goes straight to the liver. Until the 70s and 80s, 1970s and 80s, almost everyone died of this and who had the disease. And that's because, and the median survival of untreated disease was 5 to 10 months, and almost no one lived to 5 years. But it was noticed that at death, only that a third of the patients in autopsy only had disease in the liver. That's what started surgeons wanting to go remove the tumors to see what impact it would make. But there was an uphill battle. Okay, some of the biggest leaders in American surgery were against it. Teddy yesterday showed a slide of Bill Silen's quote that resection of metastases from colorectal cancer is of dubious value. And Bill Silen was both the president of the American College of Surgeons and the American Gastroenterologic Society. He was a true leader in American medicine. And as late as 1989, he wrote that he didn't believe that this was of any value. But by the turn of the century, we had lots of retrospective series that gave us good information and that resections were of value. I published one in 1999 with over 1,000 cases where the mortality of surgery was 3%. And the median survival is 42 months, okay? It went from 6 months to 42 months. And the 5-year survival of the resected patients was 36%. Okay, and this is these are just all the biggest series at the turn of the century, and no doubt from retrospective data that this was a safe and effective therapy, and that's why there's never been a randomized trial, because it was not necessary given all of these series. But I just want to point out this particular series, okay? In 2010, on a very sad occasion for me, because one of my teachers died. And his name was Joseph Fortner. He's shown here in the middle. And I just want to point out this picture. He's standing between Dr. Lee and Dr. Fraumini and Dr. Brock and Dr. Harlow, some of the most important folks in cancer research in the last century. And that's because he was also the head of the General Motors Research Foundation, and which gave out prizes and scholarships and grants for very important research work. He died in 2010 while working out in the gym, and he ruptured a vessel. He was on blood thinners for atrial fibrillation, and it was very sad for me because it was in his operating room many decades before that I wanted to become a liver surgeon, and I was a intern in his operating room. So I decided to take his personal series, 25 years, and conduct a 25-year follow-up. I called up all of the patients and looked to see what happened to them. That's because in his day, when he was doing these surgeries in the 60s, 70s, and 80s, we did not give adjuvant therapy. And this is an actual survival, not actuarial, but actual survival, 25 years of the personal series of Dr. Joseph Fortner. I was only on the paper because the Annals of Surgery wouldn't let me publish the paper without my name, without somebody who was alive. But this is really his work. And what this shows is that 20 to 25% of the patients are actually alive and cured from metastatic colorectal cancer with surgery alone, okay? Chemotherapy alone rarely cures anyone. Surgery is an absolutely necessary step in the cure of somebody with metastatic colorectal cancer. So for the young people out there, if ever the medical oncologist says, you're only doing these liver resections because our chemotherapy has gotten so good, you tell them otherwise. But adding some chemotherapy helps a lot, okay? This is a paper that Nancy Kemeny and I put in the New England Journal of Medicine 2005 with simple 5-FU adjuvant chemotherapy. We brought the 5-year survival to 45% and the 10-year survival to 30%. And by adding regional chemotherapy, FUDR, we brought the 5-year survival to 57% and 10-year survival, which is cure, to 43%. Very inexpensive chemotherapies. And we were able to achieve superb outcomes, even when the patients had many, many tumors. Then it became also clear from the work of Henri Bismuth, shown right here on a trip that Henri and I took in Tibet, that by adding chemotherapy, we can actually downstage patients for resection. He had reported in the American Surgical in 1996, 330 patients, all of whom were non-resectable by Henri Bismuth standards, okay? And those are pretty high standards. These are truly non-resectable cases. He gave them FOLFOX. That was the beginning of the era of FOLFOX. 53 patients were converted to resectable, and when resected, the 3 and 5 year survival was 54 to 40%. And that became a paradigm changing step in the history of treatment of metastatic colorectal cancer. This idea that we could take someone like this on the left, give chemotherapy, and end up with somebody like this on the right, and convert the patient to resectable. This is a further follow-up series by one of his students, Rani Adam, in 2004, and the results were confirmed that we can certainly downstage patients. So by the turn of the century, going from the 20th to 21st century, what we have learned about all of this is that 25% of the patients were curable by surgery alone. Liver resection is safe with a less than 5% mortality, and now in most major centers, less than a 3% mortality. Liver resection is effective. More than a third of the patients are 5-year survivors, and now with better and better chemotherapy, those numbers are getting better and better. And then chemotherapy may convert non-resectable cases to resectable. And with FOLFOX, it was 15%. But with FOLFOXIRI, it's approaching 30% of patients are converted to resectable. We're also starting to see this, okay? This was a patient who was put on neoadjuvant chemotherapy, came in with abdominal, with an acute abdomen. And when we scanned, at first we thought that the patient had progressed in the colon cancer. What it turned out to be was a near complete response to chemotherapy plus Avastin, and this was a perforation. So suddenly, surgeons actually ended up with more work than ever before. Not only were patients being downstaged, patients actually had complications of these complex therapies that required more and more surgery. So in reality, what has happened every time the systemic therapies have gotten better, it isn't that the surgeons had less work, they actually had more work. When you think about the traditional surgeon and where they lived in the stages of cancer, predisposition, pre-malignant, stage 1, 2, 3, and 4, generally surgeons lived here and in stage 1, 2, and 3 for cure, and in stage 3 and 4 for palliation. As we got downstaging of cancers to resectable and better adjuvant therapies, many more of the patients that we operate on in stage 1, 2, and 3 are being cured. And now we're operating into stage 4, and many more patients are being palliated. But as we understand the predisposition to cancer, the genetics behind cancer, we now have better screening. Now we're starting to operate on patients in the pre-malignant and predisposition stage to do prophylactic surgeries that prevent cancer. Who would have thought in 1984, when I graduated from medical school, that we would be doing prophylactic Whipples? And but for IPMN, that's what we're doing, and that requires someone to train so well that they can do these operations with almost no mortality and with the best outcomes. So at the present time, number of tumors no longer is an absolute exclusion criteria. I still remember when we would go only resect single tumors, then we would resect only less than 4 and then less than 10. Now there is no absolute number. Extrapolitic disease is no longer an absolute exclusion. Portal vein embolization and other techniques for enhancing liver growth before surgery is now standard. And there are many, many more adjuvant therapies that are available for use to improve the patient's survival even further. So take a patient like this, okay? It's a 45-year-old man who was otherwise previously healthy and had mild transient abdominal pain. And when a workup was done, he was found to have a sigmoid cancer, CEA 1450, LDH 1600. More than 50 tumors in the liver, including 14 on the left. Got FOLFOX chemotherapy and had no response. So he was being sent to hospice, okay? And so he came to see me in New York. And I said, well, highly unlikely that I'm going to give you long-term survival, but what are you looking for? And that's because it's always about figuring out what the patient wants and setting expectations immediately, okay? And that's because if there's a disconnect in expectations, someone is going to be not happy with the results. So he said to me, I have 2 boys in high school. I would love to move them into college, okay? And that's 2 years and 3 years away. So I said, well, maybe, but it would have to be a very aggressive approach, okay? So I took him to the operating room. I found 14 tumors on the left, as I said, and I resected 3 of them, including the one in the caudate. I ablated 11 of them with microwave, and I put in a pump for pump chemotherapy, and I left his sigmoid cancer in place because it was not obstructing, it was not bleeding. Then over a period of about 3 months, this happened, okay? All the ablated areas look pretty dead. You can see the the clip line along the resected caudate areas. You can see the pump catheter. And with regional chemotherapy, his lesions on the right started calcifying, telling me they are dying. So I went ahead and did a portal vein embolization on the right and grew his left liver. And this is the portal vein embolization picture. And that's because on chemotherapy, we can actually prevent growth of anything. And portal vein embolization works even while patients are on chemotherapy, on regional chemotherapy. The liver really doesn't care about the chemotherapy, it grows regardless. And we had proven that before. Then, after about 4 more months of chemotherapy, I took him to the operating room where I resected him, took out the right side of the liver, took out his sigmoid. And this is 8 years later, and he's doing quite well. 100% performance status, and it's been 6 years since he's been on any chemotherapy, but I have not yet said the word cure to him, okay? And that's because, again, his CEA is still not normal. It is 6.9. It's hiding somewhere. We just haven't found it yet, but he's on a hiatus from therapy, and he's not only moved his sons into college, he's seen them graduate, and this is not an unusual case for us now, okay? And but it requires someone who understands all of the therapies that are available and have trained well enough that they can do all of the surgery as safely as possible. And that's why, again, the field of cancer surgery is live and well and is really an integral part of the cure of everyone with solid tumors, except for maybe germ cell tumor. But as we get better and better at helping people survive their disease, we're also obligated to make sure there's less and less suffering along the way, okay? And that's where the minimal invasive therapies come in. I still remember talking to my senior partners and my mentors about doing laparoscopic liver resection, and there were 1,000 reasons they told me, don't go do it, okay? You can't tell where the margins are without feeling it, and you can't retract well because we don't have great liver retractors that flip the liver back and forth. We only have static retractors to hold it in place. If it bleeds, what are you going to do? And if you cut a hole in the hepatic vein, aren't you going to cause air embolism? And aren't you going to just take forever by moving instruments in and out of all these little tiny trocars? And then how are you going to take the specimen out, okay? But as I thought more and more about it over the years, it was really inertia, okay? And it's stubbornness, and it's that if somebody's really good at what they do, such as liver resections, and they are the leaders in the world, why would they ever want to go train to go do it again, okay, in a new way? And so I will say to our young people in this audience, as you get on in years, okay, remember that you were people learning once, and every time there's something new that you hear about in your field that people are saying, oh, this is the new way of doing it, at least go see it and then go try it. And if it turns out it isn't right, then give it up. But, you know, really important to see where innovation's happening and try to engage in it. So every 5 years, I go look at everything that I do and say, in that area, what's the latest people are doing? And I fly somewhere in the world, or I fly a few places in the world, and I look at it, and every now and then, I just find something amazing, okay? I was just in UT Southwestern 2 weeks ago, watching a single port nipple sparing mastectomy. And it is a really good operation. And so if you hear that I've moved to doing breast surgery, that is why. So I kept pushing, and I wrote the first paper in hand-assisted liver surgery, and I wrote some of the early papers in laparoscopic liver surgery. But what you're watching here is the very first robotic liver operation, resection in the history of the world, okay? And it was 2003, shortly after the robot came out, and we got one of the very first ones at Sloan Kettering. And I picked a very easy lesion, okay? As you can see, this is not even cancer, okay? and it's hanging in an area where it was really easy to get out. And that's because you don't always have to go harder and harder. You can every now and then go easier and see how good the technology is. And for this, it was just fine, okay? But it's very clear to me, single console you can't teach. We only had energy, we only had it as the harmonic scalpel. That's why on the right-hand side there, you can see I have a ligature coming through a separate port just in case. And we didn't have enough instruments, and smoke evacuation wasn't very good, and I didn't publish this, okay? And the first published robotic liver surgery is by Miloslav Riska, who's standing right here. He and I actually run a congress in Croatia every 2 years on liver surgery, and he's in the Czech Republic, and he published it in 2006. I didn't publish because I was worried that we would encourage people to go into doing very fancy liver work with a robot that wasn't quite ready for the task. Then the SI came along, and suddenly we did have dual consoles. We had 3 working arms and many more instruments, and I went back to it. This was one of the first ones I did robotically. It was a 50-year-old surgeon from Paris who had a history of hepatitis and had abdominal pain and was found to have this mass. He was hepatitis positive from having caught it in the operating room. It was right on the left pedicle, so there was no doubt he needed a left hepatic lobectomy. He called me and said, my AFP is 657, so it's a primary liver cancer. Can I come to New York and have you take it out for me? And I said, listen, I can name you 25 surgeons in Paris who can do this amazing, who could do amazing surgery for you. Don't come to America because it is very expensive, okay? But he came anyway. And so I operated on him, and it took 2.5 hours. And then at 36 hours, even though he said he will stay as long as necessary, he said to me, I think I'm well enough to leave the hospital. And he said, staying at the plaza is much cheaper than staying in an American hospital. Can you make house calls? So I did. And then a week later, he moved to Long Island to stay with friends. And then he called me and said, can I shovel snow today? That taught me a lot, okay? And I learned from this patient. First of all, it is possible to let people go home really fast. And second, the recovery is really good, okay? And if we had a way of quantifying how well people were doing in the first few days they're home, we will prove that robotics and minimal invasive surgery is worthwhile. So yes, we can do lobectomies, okay? And so here's a perfect lobectomy to go do. Here's a patient who had tumors in the right side of the liver that she had ablated many times because she's a 42-year-old physician that didn't want anyone to know that she had cancer, okay? And so you can see the middle hepatic vein here. The left side of the liver had hypertrophied on its own, and therefore she's not gonna miss this side very well. But after multiple ablations, you know this diaphragm right here is attached, okay? And therefore, we have to be prepared to resect the diaphragm. But otherwise, this is perfect because it's far away from the confluence of the left and right portal pedicles, and therefore we have a lot of room to work. So this was the resection. Always ultrasound, see where the pedicles are. Here we are putting a umbilical tape on the right main portal pedicle and putting traction on it. And I use an umbilical tape because it has no give, okay? Then suddenly we can actually just put a stapler across an entire right portal pedicle and that's gone. You can see the portal, you can see the right hepatic vein right there. You can see the vena cava dissected all the way up. Then we take everything in front of the vena cava. Then we take the vena cava. And then the right side of the liver is completely disconnected from the left. But notice it's still attached to the diaphragm because in most right-sided liver resections I use the triangular ligaments or adhesions or scars as traction. I use gravity as countertraction. And so again, resecting these, great visibility. There it is, the diaphragm's been resected. But closing the diaphragm, very straightforward, okay, robotically. And since it's CO2 that's in the belly and now in the chest, that absorbs really fast. So you just have to evacuate most of it. So here's the suction going into the right chest. This patient is not going to need a chest tube and therefore should recover pretty fast. So here we go. We tie it. We suck out all the CO2 and this patient is home in 48 hours. Robots also allow us to combine primary resections with liver resections, okay? And this concept of doing synchronous resections had been toyed with in the last century, but and we wrote one of the biggest papers on the subject. This is Gert Silberheimer, who is now professor of surgery at the University of Vienna. When he was a fellow with us, we wrote up 427 colorectal cancers with single-risk liver mets, and 326 of these were simultaneous resections, and we compared them to 101 stage resections. So you might say, how did you choose between the two? It turned out when the reviewer asked this and we looked at it, it turned out these 326 were consecutive. They were the last 326 we did. We just philosophically changed how we did surgery and compared it to 101 previous resections. And of these, there were 200 rectal resections with liver mets. And what we found is that very safe when you in good hands and major centers, and we had no mortality. Blood loss was much less with a single operation than with 2 operations. Hospital stay was 8 days less, and patients got to chemotherapy much, much faster. But now with the XI robot, since it's really a robot on a boom, right? We can now turn it towards the liver, do the work. We can then rotate it or move the patient and rotate it and do the rectal surgery. So here is a physician from Asia. He's an oncologist, and he was discovered to have a sigmoid cancer with positive nodes and a solitary segment 7 lesion. And he called me up and said, can I fly to California and have surgery? And I said, absolutely. And so he arrived, and here is the lesion in segment 7. Notice that the triangular ligament is intact. Gravity is pulling the liver down, that's traction. The triangular ligament's countertraction. That allows me not to use 1,000 retractors or retainer stitches. And now I have the patient in the left lateral decubitus position, because when I operate on the right side of the liver, that's what I do, because then gravity helps me. And so in 20 minutes, this lesion in segment 7 is basically excised, and we put it in a bag. These are actually kind of fun. And then we put it in a bag, and then we turn the robot. And usually we could use about the same ports. Again, we have all the tools, including argon, to go do this. And so I just leave this sitting up here for a bit. Then here's the sigmoid. And then with fluorescence, you can tell what's well perfused and not perfused. And so doing a resection of his cancer down below is also enormously straightforward, okay? And having both things done all at once allows the patient to recover very well, get out of the hospital within a few days, and he was back home to his country within 2 weeks and on chemotherapy as adjuvant, and he's doing really, really well. So as a summary for metastatic colorectal cancer, minimally invasive therapies, ablations have now proven to be highly effective and curative. Laparoscopic hepatectomy is safe and effective. Robotic surgery is safe and effective. Combined liver and colon and rectal resections are safe and effective. And laparoscopic and the robotic liver resections can be outpatient procedures, okay? Enormous evolution in the last 30 years. And those that kept up with the technology and kept up with the clinical science now are delivering the best care for their patients. So for the residents, constantly learn, okay? Some folks, the last day of fellowship is the last day they really learn. Don't be those guys and gals. Go and learn throughout your life and become better and better for your patients. Now, what's the extent we can do, okay? Here's a patient, 76-year-old, in 2013 had a T3N0 colon cancer. And then in 2016, I resected for her liver and ovarian metastases, okay? And then in 2020, 4 years later, she came back with this pelvic recurrence right here, right hydroureter. So how should we approach it? Well, now, you know, with good urologic and GYN team, we can actually approach this now robotically, okay? Here was a resection, and here's a reconstruction onto the bladder. And this patient went home the next morning, okay? And very, very different than the giant pelvic open operations we used to do, where patients would be in the hospital forever. Okay, and so again, the technical aspects of a lot of this has gotten so good that the retroperitoneal nodal dissections, urologists now routinely do germ cell resections robotically, and it's amazing how clean they get the lymphatics off all the great vessels in the pelvis. The stuff that's being done are truly amazing. What about extrahepatic disease? How hard should we push in the field? So take this case. 59-year-old presents with rectal bleeding, clearly has 2 liver metastases, and has this lung metastases on the left that's fairly large, and one on the right that we can see. Okay, very unusual that you don't see more, but that's what's this patient. Okay, so the patient goes on and gets FOLFOX chemotherapy for 8 months. That's because his oncologist was not convinced that there was surgical therapy ahead of this for this person. Liver lesions start to grow, and so because he was offered second-line chemotherapy and was quoted that it would have about a 10% chance of working for him, he went to see an herbalist. The herbalist in New Jersey said, well, I think you should see a surgeon, and sent the patient to California to see me. And taking out lung metastases, we've been doing it for a long, long time. Here's a paper from George Miller summarizing 131 resections we did at Sloan Kettering over with a follow-up over 6 years. And the 5-year survival is 31%, and the 10-year survival was 19%. This is synchronous liver and lung mets, and 61% of these patients had a major liver resection. So I brought him to California. We did a LAR, we did the liver resection, and we did the lung resection. Turned out to be a T3N0 tumor, a primary, 23 negative nodes, M1 disease in the liver, 2 liver lesions, but all of the spots we took out of the lung were complete responses, okay? So this lump that was still there on scan after chemotherapy, but was PET negative, turned out to have no viable cancer cells. So how's that possible? Well, if you would have read a paper that we wrote back in 2000, this is a paper we wrote in 2000. I wrote it with Joe Bertino. Joe Bertino is shown here. He's the man who invented 5FU, okay? And he was one of my mentors. And we actually took out a whole bunch of lung liver mets simultaneously and looked at the enzyme levels, E2F1, as well as thymidylate synthase, and they are very different. That's why lung metastases respond to chemotherapy much, much better than liver metastases. And so, again, not surprising to me that that tumor was completely dead. And it's also why we're resecting lung metastases less and less. It is very, very common now that the lung will be sterilized with chemotherapy and leaving us just the liver work to do. And knowing the scientific basis helps us. So that's why I'm kind of disappointed whenever somebody has been on chemotherapy for 2 years because they have lung nodules that precluded referral for liver resection, okay? Here's a patient on chemotherapy, full 2 years, okay? And if you take a really hard look, you can see those lung metastases, but they are kind of small. It takes a long time for somebody to die of lung metastases. If the nodules have become fixed in size, probably it's completely dead, okay? And so we wrote a paper a couple of years ago, and when I say we, it's always a royal we. It's all the fellows that do the work. And this is Camille Stewart. She was a fellow with us. She's now an attending liver surgeon at the University of Colorado. And she wrote this paper, Cytoreduction for Colorectal Metastases, Liver, Lung, Peritoneum, Lymph Nodes, Bone, Brain, when does it palliate, prolong survival, and potentially cure? So we looked at all of those, okay? If brain mets generally don't develop till very late, 33 months, okay? So the shaded line is how long it takes after discovery of the primary for these sites to present with metastases. But if it presents, okay, patients live an average of 3 months, okay? So having a brain met is a very bad thing, but it usually is a late event, and usually it's because somebody has such a disseminated disease that, that it eventually made it to the brain. Bone mets don't show up for 17 months, and generally they die within 2 months because they're usually suffering and put into hospice because bone mets hurt, okay? And then if you look at the intrathoracic, these are the lung mets. They don't show up for about 15 months, but generally people live at least an average of 18 months after that. Patients who've run out of therapy, I've seen many go years with lung mets just progressing, okay? So, and only 17% of the people who have lung mets die of lung mets. So we tend to take out lung mets, or we observe them, and they have a higher response to chemotherapy. It's an unusual cause of death. Many treatment options available, and includes resection, ablation, SBRT, embolization. What about ovarian mets? This is a 76-year-old who came to see me with this solitary liver metastasis in the right posterior sector, and clearly a right ovary that's positive with cancer. So Lucas Thornblade, when he was with us, he's now at UCSF, wrote up the California Registry series of resected ovarian mets from colon cancer. 756 of them, and if there was a solitary ovarian met, 5-year survival is 46 months and 46%, and 10-year survival 31%. So again, common occurrence. People live a long time after resection, and these are my favorite because when somebody needs a TAH-BSO, it allows me a different place for extracting the liver. And so here is the resection of that right posterior sector. And you'll notice that this is not a small piece of liver. We put in a bag. And since the patient had a simultaneous TAH-BSO, what we could really do is to extract it transvaginally. And this patient wakes up with no extraction site. And has only 8 and 10 millimeter ports. This patient goes home on the next day. And sewing the vaginal cuff is not a problem. And this suture line is not painful. So Lele Maelstrom, 2018, wrote up our last 100 robotic livers. 2/3 of the patients go home in the first 3 days, and half the patients go home in the first 2 days. So then it suddenly puts upon us a different problem. Many hospitals, the liver resection patients aren't even out of the ICU yet. And if we have them at home, how are we going to monitor them and make sure they're okay? So we started a pilot project back then using step trackers. And this is the VivoFit. I get no money from Garmin, okay? I just want to make sure you understand. But I think this is the best device ever made for this to this point, because this is waterproof, so patients can shower. It's very light, so patients could wear it all the time, and does not need charging for 3 months. So it's a true health device. So that right lobectomy you saw me do with the diaphragm, patient was working, had surgery, had a right hepatic lobectomy and a diaphragmatic resection, and within 5 days was back to 6,000 steps. In fact, she had so many steps that I called her and said, "What are you doing?" And she goes, "Well, I didn't want my colleagues to know I had cancer, so I'm back at work and taking call." Okay, that was a week later against my advice. Now we have a $4 million grant from the PCORI to monitor patients. We have a project right now where we're monitoring 800 patients at home, looking at all kinds of data, including patient-reported symptoms as well as steps, and having a call center that either, because of either the stress or low steps, calls the family. If it's really a just needed support, calls the medical team if intervention is necessary, or calls an ambulance if there are issues. Then one last clinical scenario that we are pushing hard on, okay? This has become my most dreaded scan in the afternoon, okay? Every afternoon I receive all my mail, and in the mail there's usually scans of patients who want to come see me, okay? And this is like the most dreaded situation of seeing a giant rectal tumor, but I know there must be liver metastases or it wouldn't be on my desk, and a baby in a uterus. So in the 80s, from when I was in residency, this would have meant that the baby would be aborted and the patient would still die very shortly after all of this, okay? Now, if you look at the most recent series, patients are delivering as soon as the baby is viable. And look, this was a series of 82 patients diagnosed with colorectal cancer during pregnancy. 72 were born with live newborns, and 8 of these patients actually had chemotherapy. And none of the babies had long-term disability, and one just had hypothyroidism. So now it's much more standard. And if the baby's not viable, to just give chemotherapy. And that's what we did here. Tumor shrank, delivered the baby, and then we could deal with the primary tumor as well as the liver metastasis. So I now have like a series of these. And so just to show you one of these cases, here's a 32-year-old, 2017 pregnancy with synchronous liver mets, and you can see liver mets both sides, and gave neoadjuvant chemotherapy. Baby was delivered. We resected the right with the right triseg and the left with wedges and ablations. Then the patient did really well and has not recurred in the liver, okay? Has not recurred in the liver. And this was now 3 years later, has an isolated adrenal recurrence behind a previously resected right lobe, okay? So right on the resection margin. Nowadays, we go back robotically, okay? And here is the adrenal. Here are the adrenal vessels off the vena cava. Here's the right renal veins, and we're able to get these out, and the patient was home the next day. And this is the baby now. This is the baby that was in utero, now 5 years old, and that's the mother, and she gave me permission to use the picture. She sent it to me for this purpose, and this is now another 2 years later with no signs of recurrence, okay? So again, will she recur? Probably. But has she gotten a really good life and minimal interruptions of it? As best we can deliver that. Many more robots coming. The Hugo is about to be here. The SB is remarkable. The Ion, the Monarch, they're all here, okay? This is the robotic era, and figuring out where these will be useful for your patients and learning how to use them, really important. But then having telehealth and telemonitoring to make sure your patients who go home early are taken care of, really important. We'll need to educate. Education could be remote teaching, okay? And here is a teaching system that I use. And when my surgeons are working and they are doing something nifty, many times they call me. This is me on my cell phone watching what they're doing in the operating room and getting excited and learning from it. We're going to need to write more of how to go use these robots. Pierre Claudien and I are going into our 3rd edition of our Atlas, and this next edition, the last edition was downloaded 500,000 times. And this next edition, half of it will be robotics. And very soon now, we're going to redo the SAGES Atlas of robotic surgery, hopefully with a bunch of new robotic platforms available. I'm going to end with a few slides on more philosophy. I hope you'll indulge me. Okay, yesterday, you heard an amazing talk from Carolyn about how to learn leadership, how to integrate your life. I'm going to add a little to it, okay? And what I'm going to add to it is family, it's time management, and it's finding mentors, okay? And so this is not a joke, okay? Many people spend more time on Zoom than with their children. So people talk about life-work balance, work-life balance all the time, okay? But to me, work is part of life. And what we really should be talking about is work-family balance and work-hobby balance and work anything that makes you happy balance. And a lot of it comes down to time management. And that's because time is limited. If you think about an 80-hour work week, which is in the US is what we're held to, that's 11.4 hours a day. We sleep 7 hours a day. We feed 2 hours a day. We shower and groom, and please shower and groom. That takes about an hour. We do American Idol or Game of Thrones because you can't have both because that would be each an hour. And you do email for an hour, which is never an hour. You only have 30 minutes left for everything else. Okay, so you can't do all of this and not integrate in things that make you happy, okay? And things that are important for your health, like seeing your doctor, getting your car fixed. That's why we're all stressed, okay? And so many papers, a third of the people in medicine are stressed out and burnt out. And it's mainly this perceived imbalance between career and family personal life that does that. And job interferes with personal life is rated #1. So how do you solve that? Well, I don't have a perfect solution. I just have a solution for me. And for me, it is my family, okay? And that's also why physicians and suicide is such a big deal. And much higher rate in physicians. Caroline showed you a case, a co-trainee of hers who committed suicide. I've known 9 surgeons personally who have committed suicide. And every time I go, should I have seen it coming? Could I have done more? And it's never the ones you think it's going to be. So for me, it's sharing time with my family and doing things. And so this is my family. Let me introduce you. This is my wife, Nicole, and my 3 girls, okay? Abby, Sandy, and Danielle, okay? The societal answer as to how to share time with your family is to help them with homework. I never really did that, and nor did my wife really, or volunteer at school. We didn't do much of that either, or choose between work, self, and family. And for me, however, and for my wife, it's hobbies, values, and loves, okay? And sharing hobbies, values, and loves is what we do. And the biggest love in our family is sports, okay? So we were I grew up in the 1970s when parents helped coach kids, and it wasn't professional coaches, and kids played 3 different or 4 different sports a year. And so that's what I did for my kids, okay? And my wife and we coached them in track and fencing, in swimming, and in volleyball, and in like softball, anything you could think about in sports, that's what we did, okay? And we still do. This is Abby just 2 years ago, winning her age group in the Catalina half marathon, okay? And we still go to sports things, even though my kids are now 28 to 30. But the place I coached the most was in shooting, okay? We're kind of weird. We are target shooters. And so let me introduce this sport to you. This is the shooting event that's been present in every Olympic Games in the modern Olympics. It's contested by 87 countries this last time, 3rd most of any sport. And Americans have won 44 gold medals, 3rd most for all sports. So Americans are pretty good at it, and it is a very common and popular sport in the Olympics. And this happened that I coached my kids in this because my oldest came to me and said, when she was 13, she said, "Dad, I would like to go to the Olympics." And I said, well, it's really hard. Only 200 people in America, 200 women in America go to the Olympics every 4 years. And you have to be really, really good. And you have to be talented for whatever sport you choose. And that's really hard. So we went through all the different sports, and they were really good at many sports. But they just weren't the right body type. And so this is also where surgical coaching comes in, okay? And where people will come to me and say, I want to be a liver surgeon. And I will say, how long can you stand in the operating room and still be happy with what you're doing? And that's because there are 1 hour surgeons, 3 hour surgeons, 7 hour surgeons. And if you're a 1 hour surgeon doing a 7 hour operation, you're not going to be very good. So here in the back to the sports, they said, we really like to go. And I said, well, why don't we try shooting? I was really good in shooting when I was young, and your body types may be good for it. And so it turned out all three were phenoms. This is really 5 shots from 50 meters in the wind, standing up, holding their rifle without support. And they are really good, and maybe 20 people in the world can do that. But it also allowed me to teach my kids time management, okay? And that's because then suddenly they were on the national team. They were traveling the world, doing World Cups while trying to do high school. And here is Sandy in Bangkok. She didn't have time to take her SATs in America, so we actually arranged for her to actually take the SATs at the international school in Bangkok. I was able to arrange at the same time to speak at the Thai National Congress of Liver Surgery, and I was helping the child-born princess of Thailand build her cancer center. So I got to multitask. She got to multitask, and I got to teach her time management. So it was kind of cool that in 2008, 2 of my kids competed at the Olympic Games, and it is absolutely the biggest accomplishment in my life to have coached my kids at the Olympics. And then 2 years later, when Sandy won the world championship, it was really amazing, okay? But I think through all of that, what I shared with them was how to manage time, how to go and do things and practice and get good, and the rewards of doing well. And so very, very happy that both of my children went into surgery, older children. So to finish up, okay, mentoring your kids and finding mentors for yourself, really important, okay? And so this is one of my mentors from college. He's Leon Cooper. He was one of the reasons I went to Brown University. He had won the Nobel Prize in 1964 for the Cooper couple. And I still remember asking him, how did you win the Nobel Prize when there's so many smart people out there? And he said to me, focus on what is important. It takes just as much time to study something insignificant as something important. And I've always taken that to heart, and I will say that to all the young people here. To finish up, how to succeed in academic surgery is really simple. Keep your eye on the ball. Promotion and tenure comes when you're recognized as a national and world expert. That's in every institution in the world, okay? It's not number of papers. It's not number of grants. It is that you're recognized as a national and world expert. The dean loves you, however, when you bring in grants. Director of hospital loves you when you generate hospital income. Chief of surgery loves you when you support the local sheriff, and you always have to support the chief of surgery. When the dean, the hospital director, and the chief of surgery all love you, you keep your job and get resources. Your family loves you when you can do all of the above in daylight hours and during the work week. And then going forward, engage in designs of surgical technology. It's become very complex, but if you help make it, you're going to know a lot about it. Engage in the forefronts of biology and medicine. Focus on a limited area so you could be an expert. Time management for electronic communications. Finish your charts in clinic. Don't take them home at night and do it on weekends. And do email only a few times in a day, not all day long. And tweet. Set aside time to tweet if that's really important to you. But plan your family into your week, your month, and your year. Thank you very much again for this invitation and the opportunity to interact.
Thank you so much for that great presentation, Dr. Fong. It was always as inspiring as usual. I would like to open the chat to questions if you guys have any. If not, then I'll start. Dr. Fong, could you speak more to us about how you got involved into the engineering in robotics, and how do you recommend that we start doing that if we're interested?
So there's so much in technical, in surgical tools and techniques that are being pushed forward by industry, okay? And industry is always looking for experts to help them define relevance and eventually to help market. So again, engaging is important. And so again, back in the 80s and 90s, everybody thought that if you were a consultant to a company that you must be on the take. I do it mainly because I want to see the next generation stuff coming. Okay, and the amounts of money that are involved are trivial, and so, but having an ability to influence what the next generation tools are, it's really kind of cool. So I would say every time somebody calls you and says, "I have a new startup and I'm thinking of X," don't dismiss it out of hand. See what they're doing, and then see if there's some role you can play that could make that tool real. And so that's what I've been doing, last 30 years.
Thank you. I think Dr. Bazik has a question, and then Dr. Feldman.
Yeah, thank you very much for a truly inspiring talk, Dr. Fong. I'm a breast surgeon, and I'm just wondering, in terms of resection of breast metastasis, I know it's not your topic for the day, but we've always been warned that the biology of breast cancer is very different from that of colorectal cancer. Indeed, there are clearly differences. Yet, nevertheless, it seems that with time, as we learn more and more, these biological differences are becoming smaller and smaller as we understand better the heterogeneity of breast cancer and of colon cancer, in fact. So, and also the follow-ups, of course, are very different. And so there's thought more and more that, and there's evidence, as you know, that resection also, this kind of, let's resect everything we can, that you've shown that to be successful in selected cases is also applicable in breast cancer. What are your thoughts about that in general? Did we lose him, or?
Dr. Fong, did we lose you?
I think so.
Maybe give a minute or two.
I think he's logging back in.
Yeah, he's trying to reconnect.
He's trying to reconnect. But that's a really good question, Mark. I want to know the answer.
No, because a lot of people are saying it's because of the follow-up, right? The follow-up colorectal cancer is very different. You get regular scans. We don't do that in breast cancer. So is there also a lag time? And the biology fundamentally may not be all that different. And then there's all this field now, exploding field of oligometastatic treatment, mostly radiotherapy, because radiotherapies get to it first. But, and there's long-term survivals. We're getting the same kinds of numbers that we're seeing in colorectal metastatic disease in some cases. So I think our thinking has to change. Can become a liver surgeon in old age. Scary thought.
Dr. Malik, can you hear me?
Yes, we can
Yes,
hear
we
you.
can hear you.
Oh, I'm sorry. I got kicked out for some reason from the Zoom. And so let me answer your question. Breast cancer has, in the liver metastases, has really evolved over the last few years. And in the past, more than 10 years ago, it was really rare that patients would actually have isolated liver metastases from breast cancer in such a way that it would be reasonable to resect. That's why all the series were less than 50, okay? Lately, because the therapies for breast cancer has become so good that it is possible for all of the other sites of metastases, bone and everywhere else, to become quiescent, and for liver metastases to be under control for a while, and then for a few deposits to escape therapy. And more and more, I'm now asked to resect those, both to define what the escape mechanism is and what the resistance to therapy is, and to try to keep the liver from being overtaken by resistant cells. And so we're doing a lot more liver resections for breast cancer, but usually it's in somebody who had widespread metastases, comes under really good control of systemic therapy, and now we're taking out the resistant clones. So I think of the surgery for breast and for lung cancer in the liver as adjuvant to the systemic therapy rather than the other way around.
Thank you.
Dr. Feldman, I would invite you to unmute yourself.
Okay, I don't know if we have time, but quick question. Thank you, Dr. Fong. A really outstanding talk, very inspiring, and it's great to also learn more about the man behind the throne. So just a quick question. You mentioned about ultra short stays and remote monitoring and collecting patient-reported outcomes, as well as functional status outcomes. I was just wondering how you're using that data.
We are right now trying to figure out how to use the data. We are capturing a huge amount of data all at once, and we have come to realize the steps are probably the most important. When somebody doesn't walk, they're sick, and you need to go intervene before there is a sentinel event or there's a readmission. And we're now trying to figure out how small a set of patient reported data can be for us to go get useful information. Can we go with a sliding scale of anxiety, pain, and general feeling of quality of life versus a giant series of questions in an instrument that we have to administer that takes forever? And then what physiologic data we need? We're trying to figure that out too. Does oxygenation matter? How reliable does it have to be? When we go and try to gather heart rate, it's really hard because when people are doing well and they're out doing something fun, their heart rate goes up too, and suddenly you're responsible for somebody who has a high heart rate. So all of this is now at the learning phase, and I'm so glad that we're funded for it for 3 years to go collect all the data, and would love now to go and not only figure out the answer, but to partner with other hospitals to see how far away we can monitor patients. So we are now talking to folks in other states and other countries about doing mutual monitoring and seeing whether that's all possible, and that a limited number of call centers is all we need to monitor all the surgical patients in North America, for example.
Thank you.
Thank you. I think we are running out of time. So thank you very much for all your questions. Thank you, Dr. Fong, for coming to Montreal and inspiring us all. Thank you all.
Thank you, guys. Thank you, Dr. Fong, for your two incredible talks and for sharing your wisdom.
Thanks,
Thank
Yuman.
you.